So I'd like to start by acknowledging that the University of Alberta is located on Treaty 6 territory and respects the history, languages, and culture of First Nations, Métis, Inuit, and all First People of Canada, whose presence continues to enrich our vibrant community. I'd like to thank the continuous support of Paladin for these ATI seminar series. Mark your calendar for December 2nd, 2024 in Calgary. There'll be the Gardner Symposium of Pediatric Transplantation. And if you'd like to register, the link should be in the chat. So it gives me great pleasure to introduce our speaker today, Catherine Burton. So Catherine is an associate professor of pediatric at the University of Alberta. Her clinical work is in pediatric ID with focus in pediatric transplant infectious diseases. Her research interests include immunization and vaccine preventable diseases in children, especially the immunocompromised children. She also has interest and have done a lot of work on EBV and CMV in pediatric solid organ transplant.
Thank you so much, Dima, for the lovely introduction. And thank you to ATI for the opportunity to present here today. As Dr. Kabani said, I'm going to be talking today about the use of live viral vaccines after pediatric solid organ transplant and some of the changes that have occurred over the past few years. So we will get right into it. In terms of disclosures, I am fortunate enough to have some grant funding from the following agencies that's allowed me to do some of this research, and I will be discussing the off-label use of live attenuated varicella vaccines and live attenuated combined measles, mumps, and rubella vaccines in this presentation. So I'm hoping that at the end of this session, that people in the audience will be able to describe some of the changes in practice in the use of live varicella vaccine in pediatric solid organ transplant recipients, appreciate some of the barriers and facilitators to implementing guidelines for the use of varicella vaccine, which is a big change in our pediatric solid organ transplant population, and to discuss some of the available evidence to support the use of live measles, mumps, and rubella, or MMR vaccine in select pediatric solid organ transplant recipients in the context of, unfortunately, increased global measles activity. So what are live vaccines? Not sure what everybody's familiarity is, but, as the name would suggest, they are vaccines that contain whole, weakened bacteria or viruses, and they do actually replicate in the body, and this stimulates an immune response that's similar to natural infection. Now, these organisms, as I mentioned, are weakened, so they don't replicate well in the body, so they're very unlikely to cause the actual disease in immune-competent individuals, but it's still possible for them to cause disease in individuals with suppressed immune systems. So for that reason, live vaccines are contraindicated in many immune-compromised individuals because of the fear of possible disease from the vaccine strain. So why do we use live vaccines at all? Because almost, all of our other vaccines are non-live vaccines of different varieties. So the reason that we use them essentially is that they provide really excellent, long-lasting, and very broad immunity, much more similar to what you would achieve with natural disease from some of these organisms. So which vaccines are live vaccines? So in the Alberta routine immunization schedule, there are 3 live vaccines. That would be the MMR, measles, mumps, rubella vaccine, and the live attenuated varicella vaccine, or LAVV for short. These are traditionally given at 12 and 18 months of age in the infant schedule. And then we also have rotavirus vaccine that's given in the infant schedule. There are other live vaccines. We're not going to talk about all of these vaccines today, but just for people to be aware of. So there is a live intranasal influenza vaccine that is available. And then there are other live vaccines that are used in some parts of the country, some are used in some parts of this country, some are used in other countries, and some are recommended for travel. So just for people's familiarity, but we're not going to be talking about any of those today. So live vaccines have generally been contraindicated in solid organ transplant recipients. So why would we even challenge that? Why are we talking about this today? So varicella or varicella zoster virus, when we get primary infection, causes chickenpox, essentially, which probably most people in the audience are at least somewhat familiar. But what does chickenpox or primary varicella infection look like for solid organ transplant recipients? Well, first of all, first thing to know about chickenpox, which a lot of people are already familiar with, is that it's really highly contagious. So it can be spread by airborne transmission as well as by contact. And for our immune compromised population, there is a significantly higher risk of more severe and complicated infection, including things like higher risk of pneumonia, hepatitis, hemorrhagic skin lesions, disseminated disease involving other organs, and a significant risk of secondary bacterial infection. So there is significant potential morbidity from chickenpox in solid organ transplant recipients. So how do we try to protect our transplant recipients against this? Well, the biggest thing that we try to do is to optimize the use of varicella vaccine prior to transplant for candidates that are non-immune, that haven't had vaccine or varicella infection before. So we ideally like for children to receive 2 doses of the live varicella vaccine prior to transplant, but important to note that these vaccines are recommended to be given at least 4 weeks prior to transplant. And this 4-week window is recommended because there is concern that there could still be varicella virus essentially in the blood for up to 28 days after the administration of the vaccine. And so if there was actually virus there and then you immune suppress an individual, you may increase the risk that they could actually get the disease from the vaccine. So that sounds easy enough. Why wouldn't we just give all of our transplant recipients a couple of doses of live varicella vaccine before transplant and not be worrying about using these vaccines after transplant? Well, unfortunately, there are a lot of challenges when it comes to optimizing pre-transplant varicella vaccination in pediatric solid organ transplant recipients. Some of those challenges include the young age that transplant often occurs for some of our recipients, especially our heart transplant recipients and sometimes liver transplant recipients. So traditionally, varicella vaccine is not given until 12 months of age. We can give it earlier in our accelerated schedules at 6 months of age, but there's not a lot of experience giving it younger than this. And the reason that we typically hold off and give it later is that when children are really young, they often have passive antibodies that come from their mothers, and those passive antibodies can actually interfere with the child's response to the vaccine. And so that's one of the reasons that we delay giving these vaccines until a later age. So difficult to give them if we have kids that are getting transplanted at less than 6 months of age. Now, the second thing, obviously is also the urgency of transplant. So, for some of our kids, they need a transplant quite urgently, and they don't have time to wait or to be put on hold on the wait list for 4 weeks after getting live vaccines. It's just not practical. Other things that make it challenging are that a lot of these children have received blood products, and just as you can have passive antibody interference from antibodies from the mother, you can also have passive antibody interference from antibodies in blood products. Now, we do often still give these vaccines, even if kids have had blood products, but their response to vaccines may not be as robust. And then in some situations, there are kids, depending what their indication for transplant is, but if it's something like, a hepatoblastoma, that kind of thing, they may already be on immune suppressing medications for their underlying disease. And so the live vaccine would already be contraindicated even prior to transplant. So one of the questions that we've been asking for a few years now is, do we actually need to wait this 4 weeks after giving live varicella or measles, mumps, and rubella vaccines? Do we need to wait the 4 weeks between giving the vaccine and actually allowing a patient to have a transplant? So a recent study has looked at the detection of measles RNA and varicella DNA after administration of the live MMR and varicella vaccines in a group of children that had chronic liver disease. And what they found, interestingly, was that there was no measles virus RNA detected in the blood in any of the 21 participants at day 14 or later, so 2 weeks after the vaccine was given. And for varicella, the varicella DNA was detected in the blood of just one child at day 21. They didn't look at rubella or mumps RNA in this study, but this is interesting. And I guess what I ask myself is, would that make a difference if we could shorten the time between live vaccination and transplant to something like 2 weeks? Would we be able to actually get more kids vaccinated prior to transplant? So another question to ask is, are there any non-live options for immune-compromised individuals? Generally, when there are options for non-live vaccines, we would choose those because they would be considered to be so safer for immune-compromised individuals. So is there an option for varicella vaccination for primary varicella prevention for a non-live option? And the simple answer to that is no, but the more complicated answer is that people are looking. So Dr. Kumar's group in Toronto has evaluated the use of the non-live herpes zoster vaccine for the prevention of primary varicella. They've just evaluated the use of this vaccine in a small group of adult solid organ transplant recipients that included lung, liver, and kidney transplant recipients that were non-immune to varicella. What they found was that just over half of the individuals in this group had a positive antibody response after getting 2 doses of this vaccine, and there was evidence of some cellular immune response as well. So difficult to know what this means. Perhaps this vaccine may have some benefit for these patients, but it certainly doesn't seem to work as well as the live vaccine overall in terms of stimulating response. And the recombinant zoster vaccine has not been studied in children up to this point. Okay. So what about post-transplant if you have individuals who are not immune to varicella? So first of all, who is immune? Who's typically considered to be immune to varicella? Generally, people would be considered immune if they have received 2 doses of varicella vaccine, or if they had lab evidence of varicella immunity, so like a positive varicella IgG. Now, this, really applies to the general population, and it's not totally clear whether actually having evidence of 2 doses of varicella vaccine in certain immune-compromised populations, in fact, makes them immune. And for the purposes of post-exposure prophylaxis, generally, if an immune-compromised individual has a negative varicella IgG, they would be considered to be susceptible. So what do we do if a susceptible solid organ transplant recipient is exposed to varicella? Well, generally, we try to give varicella immune globulin within 10 days of the exposure, ideally within 4 days, because that's where the best evidence is for actually preventing varicella infection, but it can be given up to 10 days after the exposure. And sometimes antivirals are used. Now, the caveat to all of this is that the recipient has to actually know that they have been exposed to chickenpox, which is not always easy because this, can be airborne, and so they may not even be aware of the exposure and may not be able to access post-exposure prophylaxis appropriately. So, because of all of this, given the challenges of optimizing live vaccines before transplant, the potential severity of disease, and the burden associated with post-exposure prophylaxis, the pediatric transplant community was asking the question, could live varicella and measles, mumps, rubella vaccines actually be safely used after transplant in some cases. In February 2018, there was a consortium in Toronto where a group of over 30 experts, including ID physicians, immunologists, transplant scientists, and pharmacists, met and reviewed the existing evidence around the use of live vaccines in pediatric solid organ transplant recipients. And after this, there were expert recommendations that were developed. So the general guidance from these guidelines applies to both varicella vaccine and the measles, mumps, rubella vaccine, although the recommendation was that for MMR in areas with low incidence of measles was to restrict the use of MMR vaccination after transplant to local outbreaks or planned travel to high incidence areas. So we're going to be talking first about varicella vaccine. So from this consortium, the guidelines, you developed this cautious approach using a stoplight system. So for the red light, here, these would be patients in whom they would not recommend that they use live vaccines after solid organ transplants. So these are patients that would be, clinically unwell, currently have rejection, are on high-level immune suppression, have recent use of other immune modulatory agents or biologics, have an underlying primary immune deficiency, and importantly, at the time of the consortium, it was suggested not to use live vaccines in heart, lung, or multivisceral transplant recipients because of inadequate data available. And for at least the lung and multivisceral transplants, the thought that they were more highly immune suppressed than, for instance, liver and kidney transplant recipients. The yellow light category is the proceed with caution category. So this would include patients that are on more than one immune suppressing medication, including those that are on MMF, in addition to something like tacrolimus, or have a history of the use of ATG or rituximab at least a year prior, or for patients that have persistently elevated EBV viral loads or infection with other immune modulatory viruses. These would be patients where we would proceed with caution and may need more immune investigations prior to determining if they may be eligible to receive live vaccines. The green light group would be patients in whom live vaccines post-solid organ transplant would be considered to likely be safe. So on the next slide, I'll go through the timeline, immune suppression, and immune criteria. They would obviously have to be agreeable to this and would be recommended to have active and passive surveillance mechanisms for adverse events after vaccine. So I've outlined here the suggested or kind of criteria that would help somebody to fit into this green light category. So for pediatric solid organ transplant recipients, the guidelines suggested looking at liver and kidney transplant recipients who were at least a year post-transplant and at least 2 months post a rejection episode. In terms of minimum immune criteria, they were to have a normal or an absolute lymphocyte count and a CD4 count and total serum immune globulin within the normal limits for their age. And in terms of immune suppression criteria, they should be on tacrolimus with levels of less than 8 or cyclosporin with levels of less than 100. And if they were on steroids, less than 2 milligrams per kilogram per day or less than 20 milligrams per day total. So I just want to very briefly review what the evidence actually says about the safety and immunogenicity of the use of live varicella vaccine in select pediatric solid organ transplant recipients. So in brief, multiple small studies support the immunogenicity and safety. The majority of the data is in pediatric liver transplant recipients with some data in kidney transplant recipients, but the majority of pediatric kidney recipients are transplanted at an older age, and so most of them would have received their live vaccines prior to transplant. So the studies involved over 700 pediatric transplant recipients, and immunogenicity was reported for about half of this population, about 350. The pooled proportion of pediatric solid organ transplant recipients who seroconverted was about 88% and was comparable between studies involving different organ groups. Not terribly surprisingly, there was improved seroconversion in studies where 2 or sometimes 3 doses of varicella vaccine was given. And there was very, very little data available in adults, essentially just case reports. So what about the safety of the vaccine? Because that's probably the primary thing on everybody's mind. So safety outcomes were reported for about 650 children. 13 in this group of 650 had suspected vaccine strain varicella infection. Only 2 were actually confirmed with testing. The other 11 had a vesicular rash that happened between 1 and 34 days after vaccine, and they were treated with antivirals for possible varicella with good recovery and no ongoing issues. There was 1 report of graft rejection that occurred after vaccination, but it was difficult to determine whether this was actually related, as the details were not clearly described in that study. There was some sort of rash that was reported in just over 10% of recipients, which is higher than the kind of 5% that we see in the general population of children receiving this vaccine. But as I mentioned, only 13 of them had suspected varicella strain rash and infection. Okay. So since this consensus statement was published in 2019, there have been significant efforts in the pediatric solid organ transplant community to optimize protection against varicella in pediatric solid organ transplant recipients. Many Canadian and US transplant centers are now administering the live varicella vaccine to select pediatric liver and kidney transplant recipients. And at least one center and some centers are administering the vaccine to select pediatric heart transplant recipients as well. So I did just want to mention one study that has been done since the consortium in pediatric heart transplant recipients out of Sick Kids in Toronto. So as I'd mentioned in the consortium guidelines, it was recommended not to administer live vaccines in pediatric heart transplant recipients because of lack of evidence to support safety and immunogenicity. So shortly after that guidance was published, the heart transplant group at Sick Kids published their experience with the use of live varicella vaccine in a group of 31 pediatric heart transplant recipients. The median time post-transplant to receipt of varicella vaccine was about 9 years. Most of the recipients were on either tacrolimus monotherapy or were on tacrolimus and MMF together. Of the group of 31, 17 had varicella serology after receiving at least 1 dose of varicella vaccine, and 16 of 17 had a positive varicella IgG or positive varicella serology. In terms of adverse events after vaccination, so 9 of the 31, so about 30%, developed a rash of some sort after vaccination. The average time was just over 2 weeks after vaccination. Most of these rashes were a limited number of spots that self-resolved in a few days. Only 1 rash was vesicular in nature. And only 1 patient was actually treated with oral acyclovir for 7 days because they developed about 20 spots after receiving the vaccine. All of the others resolved without any treatment. This group has stated that there will be further information available regarding serologic follow-up for the remainder of their participants once they have received the 2nd doses of their vaccine. So what do we take away from this study? Well, the frequency of post-vaccine rash is certainly higher than what has been reported in the pediatric liver transplant recipients. It was somewhat reassuring that all of the rashes did resolve without any treatment. So perhaps there may be a place for the use of this vaccine in certain situations in pediatric heart transplant recipients, though clearly more research into this is needed. Okay, I want to move on now to discuss some of the live vaccine work that we have been involved with here through the Special Immunization Clinic Network. This is a network that's led by Dr. Karina Top, who at the time of the study being started was in Halifax, but she is now a member of the pediatric ID division at the U of A. So the Special Immunization Clinic Network is part of the Canadian Immunization Research Network, and it includes 13 special immunization clinic sites in 7 provinces across the country, including sites in Edmonton and Calgary. It's a unique network of infectious diseases specialists and allergists that supports public health and other physicians in the management of patients with unexpected, severe, or serious adverse events following immunizations, as well as patients with underlying medical conditions that might affect the response to immunizations, including children with immune-compromising conditions. So the SIC network identified optimizing varicella vaccine immunization or varicella vaccination in children with solid organ transplant as a key priority and developed a plan to help implement and evaluate the guidance from that 2018 consortium. So this involved the development of institution-specific clinical protocols informed by the guidance from the consortium, but also with local input from transplant teams, as well as public health and whoever would be providing the vaccines. Additionally, a mixed methods multi-center research study was developed to identify barriers and facilitators to implementation of a clinical protocol, which would inform protocol revisions and broad implementation of this guidance. Additionally, we aim to evaluate the safety and immunogenicity of the live varicella vaccine given according to these clinical protocols that were developed. So this is just a look at the clinical protocol that we developed here at the Stollery Hospital. So essentially, the pediatric kidney and liver transplant teams helped to identify liver recipients that had a negative varicella IgG, and those that had received less than 2 doses of live vaccine prior to transplant. If they felt that it would be appropriate for them to be assessed for eligibility for varicella vaccine, they refer them on to the special immunization clinic, where they had some additional investigations and a history to determine whether they might be eligible to receive live varicella vaccine. If they were, then they were referred on to public health for varicella vaccine administration, and then they got telephone follow-up from our special immunization clinic team at 10 and 30 days after live varicella vaccine was administered, and varicella serology at least 30 days after receipt of vaccine. So just looking at the criteria that were included in the clinical protocol, so patients needed to be at least a year post-liver or kidney transplant, clinically stable, with a negative varicella IgG. And here we only looked at kids that had less than 2 doses of live varicella vaccine pre-transplant. Needed to be on what was considered low-level immune suppression, which generally was either monotherapy, most commonly with tacrolimus, or we also did evaluate them if they were on additional agents like MMF and steroids. They had to have their total lymphocyte count, CD4 T cell count, and serum, total serum IgG within normal limits for age, and importantly, needed to be confident that they could follow up for evaluation of potential adverse events. So patients, if they were assessed to be eligible, they were advised essentially to seek medical attention promptly if they had new onset of rash or high fever. And as I mentioned before, they did get routine telephone follow-up to look for any adverse events after vaccination. So we knew that the only way that this was going to work in Alberta was if we worked with public health, because they are the ones that administer our vaccines in Alberta. So we worked with public health in Alberta to have the immunization schedule for children with solid organ transplants updated to reflect that select pediatric liver and renal transplant recipients would be eligible for varicella vaccine. And we really felt it was important, if we were going to be implementing this change, that the process for vaccination remained the same, with vaccines being given by public health, so we could ensure that this practice was sustainable moving forward. So I have some very preliminary data from our evaluation of safety and immunogenicity of the live varicella vaccine at transplant centers across Canada that I can share with you today. We literally just received this data set days ago. So this is very preliminary, and I don't have as many results to share as I was hoping that I would, but I will share what we have nonetheless. So across Canada, we were able to enroll 59 pediatric solid organ transplant recipients that were eligible to receive post-transplant live varicella vaccine. The mean age at transplant was just under 2 years of age. And important to note that more than half of them were transplanted at less than 12 months of age, which kind of makes sense that they were unimmunized or under-immunized for varicella, because as before, this vaccine isn't usually given until 12 months of age. In terms of organ transplanted, our data looks very similar to the rest of the literature out there. Majority were liver transplant recipients, with a few kidney transplant recipients and a couple of heart transplant recipients as well. The mean time from transplant to the administration of the live vaccine was 7.75 years. And about 40% of this cohort had received at least one dose of live varicella vaccine prior to transplant. A few had received 2 doses, and one apparently received 1 dose prior to transplant. So again, this is very preliminary data, but for the data that we do have, looking at seroconversion to positive varicella IgG, 11 of 16 recipients had serology done after receiving 1 post-transplant dose, 16, and 11 of the 16 had seroconversion to positive varicella IgG, and 28 had serology done after receiving 2 post-transplant doses, and 24 of the 28, or about 86%, had seroconverted to positive varicella IgG after receiving 2 doses of post-transplant live varicella vaccine. I unfortunately don't have more information in terms of the breakdown and some of the other variables that we are going to be looking at, but we will have that very soon, and certainly will share it with the transplant teams. The safety data also is currently being analyzed, so that will be yet to come. Some learning along the way, something that we found at all of the centers that were involved, is that there were a lot of pediatric solid organ transplant recipients that fell into the yellow light kind of category, the caution with live vaccines category, versus the green category, which is not all that surprising because these are complex patients, often with many things going on. And so going forward, I think that our group, as well as other groups in other countries, are going to be looking at better ways to ensure that our guidance is able to apply also to the recipients that fall in this kind of yellow light category, with suggested additional evaluation. Okay. So now I want to move on to something that I found to be a really fascinating part of this project and this experience, and was really important, I think, to the use of live vaccines after solid organ transplant. And that is really looking at, whether or not the use of live vaccines after pediatric solid organ transplant is acceptable to the transplant teams and the families, and what some of the barriers and facilitators to implementing this new guidance might be. So administration of live vaccines after solid organ transplant is a huge paradigm shift in immunization practice. And in order to implement varicella vaccination, we really need to determine the acceptability of this practice to healthcare providers involved in the care of pediatric transplant patients, as well as parents and caregivers of solid organ transplant recipients, and identify barriers and facilitators to use of this vaccine. So this is, I will admit, my very first experience in qualitative research. I'm very grateful for the incredible guidance from the team at the Canadian Centre of Vaccinology in Halifax. to help me through this this really rewarding experience. So what did we do in this study? We interviewed 34 participants, and that included 18 parents of children that had solid organ transplants, and 16 healthcare providers that included nurses, physicians, pharmacists, and social workers that worked with the transplant teams. The interviews explored perceptions of vaccines, views on this new live vaccine guidelines, and vaccine intentions. An interpretive description approach was used, which essentially entails starting with what you know about the issue or the process you're trying to study, looking at the data, seeing whether it confirms or is against your ideas, and then modifying your theory. And the idea is that it blends academic knowledge and clinical experience to explore these health-related topics with the goal of really generating practical recommendations and observations to inform healthcare practices. And through this study, we found there were 4 major themes that arose with respect to the use of live vaccines after pediatric solid organ transplant. So the first was one of foundational information. So we found that pre-transplant counseling was really a milestone for many parents that participated in the interviews and was identified as a really important event by many of the healthcare providers. The information provided during the pre-transplant counseling was really the foundation of the way that parents viewed risk, vaccines, and guidelines changes. And parents described receiving a very strong message that their child should never, ever get live vaccines after solid organ transplant. And healthcare providers described providing this strong message to their parents. In general, parent participants appeared to accept these messages as accurate, and they integrated them into their conceptualization of safety for their children. The second theme that arose was one of adaptive leadership. So parents really described taking on very active roles as leaders in their child's care, rather than being passive recipients of information. Parents and their child's transplant experiences are a lifelong experience, and the families describe engaging in behaviors that help them to overcome the challenges that they face in having children that have solid organ transplants. Some parents described that they already had strategies that they had adopted to try to protect their children from things like chickenpox, knowing that they weren't protected by immunization and thinking that they never would be. And over time, some felt that they became comfortable with these strategies and grown to prefer them to the uncertainty of having their children vaccinated against varicella. The third theme that arose involved communicating the evolving evidence in care. So parent participants may have understood their child's ineligibility for post-transplant vaccines, live vaccines, to be a lifelong certainty because of when and how it was presented to them. It didn't appear that it was discussed with parents that the foundation of research-based evidence that informs healthcare can change and evolve over time. And so parents may have lived with this certainty for years without knowing it might change as new research-based evidence was integrated into care. And I really feel that the COVID-19 pandemic has really, really brought this issue to light as well, when guidelines and evidence was changing so rapidly, and has really prompted a lot of us to think about the way we communicate with other healthcare providers, as well as with patients and families, when there are many unknowns and evidence is evolving rapidly. The last important finding that I wanted to discuss was that healthcare providers may vary in their comfort level with post-transplant use of live vaccines based on their familiarity with the evidence supporting the safety of this change, their clinical experience and training, and that of their colleagues. And it was felt that communicating this change to parents and providing satisfactory answers to their questions might be challenging if the providers themselves had lingering questions about gaps, which makes sense. Many providers identified that they would appreciate additional supports and guidance in counseling parents and patients, and felt that it was important that this information was shared by the transplant team as a whole rather than by one specific individual. So based on these results, the team proposed 3 kind of insights regarding communicating the changing recommendations with the use of varicella vaccine in select pediatric organ transplant recipients. So first, very important for healthcare providers to understand and communicate to families how and why guidelines and recommendations change over time. The trust between healthcare providers and families obviously facilitates communication, especially of challenging issues. And information about new guidelines or evidence should be communicated in a family and child-specific way that resonates with parents' roles as leaders. So what's the potential impact of these studies undertaken through the special immunization clinic? Well, we're really hopeful that we can use some of this evidence to inform the implementation of protocols for use of live varicella vaccine in pediatric solid organ transplant recipients across Canada, and are preparing educational materials to support this implementation. Also, some of the guidance for the use of live vaccines after pediatric solid organ transplant is changing. The Canadian Society of Transplantation and Canadian Immunization Guide both recognize the use of live varicella vaccine in select transplant recipients. So now I want to turn our attention to another vaccine preventable disease that has unfortunately been making a lot of headlines this year, and that's measles. So there's been a significant increase in measles activity globally, and we've been affected close to home with measles exposures, hospitalizations, and even reported death in a child in Ontario. So what do we know about measles in solid organ transplant recipients? Well, we know that measles is highly contagious, similar to varicella, and we do know that there appears to be higher risk of severe and complicated infection in immune-compromised individuals, especially with higher rates of lower respiratory tract infection and neurologic complications, including encephalitis. Measles can also cause things like hepatitis, myocarditis, as well as bone marrow suppression, and can significantly increase people's risk of getting other infections because it is immune compromising in and of itself. And just another important note about measles and solid organ transplant recipients is that it can be very difficult to diagnose because a good proportion of immune compromised individuals may not have the characteristic rash of measles or may not have a rash at all. So how do we prevent measles in our transplant recipients? Well, again, like varicella, ideally with 2 doses of the live MMR vaccine prior to transplant for non-immune candidates. But again, this needs to be given at least 4 weeks prior to transplant. At least that's what the current guidelines recommend. And how about post-transplant? If we have patients that are not immune, so who is not immune? People that have had less than 2 doses of measles-containing vaccine or that don't have lab-confirmed evidence of measles infection or immunity. Generally, people that are born before 1970 are considered to likely be immune to measles, but this is not something I think we should be relying on in our solid organ transplant population because of the potential risks if they were to get exposed to measles. So probably would suggest checking measles IgG even in individuals that are born before this time to determine whether or not they in fact are immune given the increased circulation of measles right now. So if we have non-immune recipients, what do we do to try to, if they have a measles exposure, to try to prevent them from getting measles? Well, again, we use, in this case, human immune globulin, either IMIG or IVIG, ideally given within 6 days of exposure. But again, people have to know that they're exposed, and sometimes that's difficult, and then they have to present to hospital and get a blood product that, isn't completely benign and certainly is associated with a lot of inconvenience and expense as well. So for this portion, I thought that we could just have a little case for thought. So what if we have an 8-year-old boy who had a liver transplant at 7 months of age, wasn't able to get any varicella or MMR vaccines prior to transplant, but was sent to the SIC clinic after transplant, and was determined to be eligible to receive the live varicella vaccine. He got the vaccine, had a positive varicella IgG 8 weeks after his 2nd dose, and didn't have any adverse events after immunization. Now, his family is planning a 6-month-long trip to a measles endemic country, and they wonder if their son could get MMR vaccine. So what does the guidance say about this? So The vaccine consortium, as I mentioned, suggested that in low incidence areas, recommendation would be to restrict the use of MMR after transplant to local outbreaks or planned traveled high incidence areas. So it seems like he is going to a high incidence area. So perhaps that would be something that would make sense for this patient. So what are things that are to think about in this case? So number one, it's very reassuring that he has tolerated the live varicella vaccine and developed protection from it, because that gives us evidence that his immune system is functionally able to tolerate a live vaccine as well as to actually respond to it and develop protection. Another thing to consider is that giving MMR vaccine to this patient would be done in a controlled setting with a known exposure, versus if we don't give MMR vaccine and he's not protected, there would be unknown potential exposures if he's in an area with increased measles circulation. So why am I talking about MMR separately from varicella vaccine, and why wouldn't we just treat them exactly the same way? Well, it is a little bit scarier to think about giving MMR vaccine versus varicella vaccine to these patients, because we have effective antivirals for varicella, but we don't actually have effective antivirals for measles or mumps or rubella. So we don't have that kind of easy out if we were to need to treat somebody who actually developed disease from measles, mumps, rubella. So since the consortium in 2018, there has been increasing study of the use of MMR vaccine in pediatric solid organ transplant recipients. So there was a US study that involved 18 institutions in the US and 236 pediatric solid organ transplant recipients, most of whom were liver recipients, received at least one dose of MMR vaccine post-transplant. 86% developed protective measles antibodies, and there were no serious adverse events. One child had possible mumps with some transient subauricular lymph node swelling about 3 weeks after MMR that went away on its own. There were no measles cases and no rubella cases, and no organ rejection episodes identified within 1 month of vaccination. So I think that many people in Canada and other countries are thinking of moving forward with MMR vaccine for select pediatric solid organ transplant recipients. So what's important to think about here? So engaging our solid organ transplant teams, as well as public health and vaccine providers and pediatric solid organ transplant recipients and their families, and drawing on the lessons that we learned about implementation of the use of live varicella vaccine will be very helpful here too. We may consider using MMR vaccine for susceptible pediatric solid organ transplant recipients, especially those who have tolerated varicella vaccine post-transplant. Now, questions remain: would we use it as pre-exposure prophylaxis, or would we limit it to post-exposure prophylaxis, which would be a lot more challenging, I think. So I'll have to mention just a little bit about adults before we wrap up here. So how about using live vaccines in adult solid organ transplant recipients? Well, really, there's exceedingly little data in this population. So I think that a first step is really to consider what are the needs, what proportion of our adult SOT recipients are even susceptible to varicella and measles. That would be a good first step, a thing to think about. And then think about, would we be able to apply similar criteria for live vaccine administration in solid organ transplant adult patients? Would it be dependent on age? Would people feel comfortable vaccinating perhaps a 19 or 20-year-old, but perhaps not a 70-year-old? Would we need to do more immune investigation? Is there a significant impact of other comorbidities that some of our adult transplant recipients might have? And, also, would this be acceptable to healthcare providers, their patients, and their families? So all things to think about. So that's all that I'm going to talk about today. I want to leave a few minutes for questions and discussions if there is anything, but I hope that that everyone has gotten an idea of how things have changed, certainly with the use of varicella vaccine and to some extent MMR vaccine in our pediatric solid organ transplant recipients, some of the barriers and facilitators that came with implementing this new guidance for the use of live vaccines after solid organ transplants, and that people think a little bit about the potential use of MMR vaccine in some of our pediatric organ transplant recipients, especially in the context of the recent increased global measles activity. So I am very grateful to many funding agencies for the support to be able to complete my research, as well as to the wonderful teams of people that have been involved and really key in all of this research. And with that, I will open it up to questions or even thoughts.
Thank you, Catherine. That was an excellent presentation. I really enjoyed it. I'm going to start to ask you the first question, but please feel in the audience either to put your questions in the messages or unmute and ask Catherine. So Catherine, we have few patients that have not received varicella vaccine before transplantation and now are either going to school or going to work, and they're in the red category where they're on triple immunosuppression, where there's not enough adult data. And with the paper that you've mentioned by the group in Toronto, where they gave the herpes zoster vaccine, so would you consider giving these patients the herpes zoster vaccine, and would you feel comfortable saying that they have some protection if they've had the exposure after they've only received the herpes zoster vaccine?
Yes, I mean, that's an excellent and very practical question. I think that there's little downside to administering the herpes zoster vaccine, but I wouldn't feel comfortable based on the limited evidence and the fact that even in that cohort, only about half of those patients actually responded to vaccine. I wouldn't feel comfortable saying that they are necessarily protected in the event of an exposure, but they may have some protection, and it may be better than nothing. And as I said, we don't always know whether people have been exposed, right? You know, it's impossible to know, and we don't always know in good time anyway. So there's probably not a lot of downside, but I wouldn't at this point have the confidence to say that after receiving that vaccine, they would be reliably protected against primary varicella infection.
Thank you. I see Simon has a question.
Yeah, that's actually the perfect segue because it goes exactly down that line. So, I mean, I've seen kids getting community-acquired, community-acquired chickenpox after having been fully vaccinated prior to transplantation. So obviously they lose their immunity to some degree. And then we all know that serologic values for live vaccines are not reliable neither way, right? Like you can get sick with antibodies, you can not get sick without antibodies. So what's your kind of, because, sorry, I missed part of your talk there because I was only able to join later. Maybe you mentioned that, but to my knowledge, there's no good evidence yet for what the clinical impact really is of the varicella vaccine. We know they develop antibodies, but are they really protected? And so what do we do if they develop antibodies and then 2 years later the antibodies are gone again? Do we revaccinate them 55 times? Because then I would at some point be concerned that we might cause trouble.
Yeah, so I mean, they're really good questions, Simon. And we do know that some of the antibodies do wane over time, whether it's from pre-transplant vaccination or there have been a couple of studies.
No, not always.
Have shown that the patients that are vaccinated post-transplant do also have waning of that immunity. And in one of the studies, they did give booster doses of vaccine with seemingly a good response. But as you point out, we don't necessarily know what that means clinically. Now, I have never seen a patient that has had very severe disease post-transplant that has, protective varicella IgG prior to getting that disease. I don't know whether you have or not. So I think that there probably is some comfort in seeing that they have that, but it's not perfect. I think that they're less likely to get more severe disease, but exactly how that correlates, we don't know. And then it depends what assay you use, because our clinical varicella assay that we use, for instance, here, often is not very sensitive actually compared to some of the other assays that are available. So we will have patients that, have had 2 doses of vaccine and still have a negative varicella on the assay we use here. But if we use the more sensitive research assay done in NML, they actually do have evidence of what would be considered in the literature protective antibodies, right? So do we keep boosting them forever and ever? I mean, probably not. But I think what we're really looking at here, the most important group that we chose to focus on were the kids that weren't able to get vaccinated at all prior to transplant, or only were able to get 1 dose. And we thought we could at least do something for them, probably to help at least mitigate the risk of severe infection.
So those kids, you would only give 1 dose then, and not a full baseline vaccination?
So
They've never had a vaccine before?
If they've never had vaccine before, we gave them 2 doses, assuming they tolerated the first dose. If they'd had a dose of vaccine pre-transplant, we started by giving them 1 dose and checking their serology. And if they didn't respond, we moved on to give them another dose. There were different clinical protocols at different institutions. Yeah, sorry.
Dr. Halloran had a question.
It's a great presentation, Catherine. It's good to see you again. It occurs to me now that we're on the verge of some new treatments, immunosuppression treatments for people, particularly with antibody-mediated rejection. And how much vigilance has there been for the effect of heavy immunosuppression on the replication of the live virus? Is there a potential we'll get complications from the live virus as we undergo different types of heavy immunosuppression for rejection?
So do you mean people that have had live virus vaccines like in the past, and then would be getting these novel kind of immune suppressants? Well, right. So I mean, essentially that's why the guidance has always been to avoid giving the live vaccines for at least 4 weeks prior to really the administration of any kind of immune suppression, because you essentially just need to get the virus out of the bloodstream, right? And I did mention that one study that looked at the genetic material for the varicella and measles after the live vaccine, and they didn't detect any measles RNA in the blood after 14 days, or varicella really after 21 days. So I think after that point, the live vaccine really shouldn't be a problem, regardless of immune suppression, is what I think right now. But I mean, the immune system's complicated. So I guess I can't say that with 100% certainty, but that would be my feeling.
Well, we probably should be making more use of the TTV test where we can actually measure the degree of immunosuppression. I hope that we can now get access to TTV testing so we can actually tell how immunosuppressed these patients are. But we know that virus replicates in relationship to heavy immunosuppression. And I just wonder, the benefits of a live vaccine must be that there's still some live virus replication somewhere. And that we have the potential for getting, anyway, just thinking about what the incidence for a particular patient might be with that, what the need for heavy immunosuppression.
Yeah. I mean, I totally agree. If there was a way that we could establish kind of the patient's net state of immunosuppression using something that was, actually objective, that would be extremely helpful in determining, which patients might be eligible, including adult patients, that might be eligible to receive these live vaccines. But it's a difficult thing to do.
Well, do you have access to the TTV testing?
I don't think that we have ready access to tortinovirus testing for clinical purposes, not as far as I'm aware. We've done some research with it, but I don't think it's easily accessibly clinically, but somebody can correct me if I'm wrong.